Greetings to you all. I want to thank SciTech Central Conferences for giving me this opportunity to speak on the study that we have done on screening of cervical cancer. It's a great privilege for me to be on this platform, sharing it with many great minds. So let's just go ahead and start on the presentation. So this study that we did with the screening of cervical cancer was a pilot study which involved EVA, which is enhanced visualization of the cervical cancer. Now, this study was actually then published in Pan-Asian Journal of Obstetrics and Gynecology, and the article was entitled Prevalence of Cervical Dysplasia and Cervicitis in the South of India, Standard Cytology versus Mobile Colposcopy. Now, the authors of this article were myself, Dr. Mallika Samuel, and I was the lead investigator for this pilot study. It also comprised of people from the Apollo Research Department and those from Mobile ODT. The disclosures are Kathy Seaborg, C.W. Peterson from Mobile ODT, and C.W. Peterson also sits on the board of directors, and then me, Mallika Samuel, who is also a consultant for the Mobile ODT. The funding for this project came from the World Bank, from the IFC Tech Emerge program. The article was published in Pan-Asian Journal of Obstetrics and Gynecology in the edition of September to December of 2019. Pan-Asian Journal is a journal of obstetrics and gynecology, and it's a peer-reviewed journal which is dedicated to therapy updates and to latest case studies and researched articles. It's indexed in Copernicus, JGate, etc. And we are privileged to be a part, to have featured in their publication. I must tell you the key takeaways of this project. Now, the mobile colposcopy enabled rapid visual assessment of the cervix and documentation of patient information right at the point of care. That is very important. Secondly, the digital health enabled device improved integration of clinical data from various sites. I just want to say a few words about cervical cancer globally. Now, you are all aware that cancer cervix is a tremendous problem that we have to wrestle with. 311,000 deaths per year. 90% of the deaths occurring in lower middle income groups, affecting women of childbearing age, shaking up the family, because the women are unwell. Diseases affect underserved communities like the rural, inner city, and immigrants. Prevalence particularly high in special populations like women who've been raped, assaulted, HIV positive, immunocompromised, refugees, sex workers, prisoners, and others. Incidence of cervical cancer worldwide, these are Globocon statistics. You see the areas which are dark brown. These are the areas where there is a great increase in cervical cancer. You see this in Africa, certain places in South America, and in Southeast Asia. Just a word about cervical cancer in India. India has made great progress in in healthcare infrastructure in recent years. But in spite of that, we have 1/3 of deaths due to cervical cancer in our country in the age group of 18 to 44 years. And cancer cervix is the second most cancer in women after breast cancer, accounting for about 14% of all female cancer cases. Now, Globocon statistics of the year 2012 tells us that in a year in India, 122,844 women had cancer cervix, and 67,000 of them died. And we see that this higher mortality rate is because of the lack of appropriate healthcare infrastructure. Now, in spite of these mind-boggling statistics, only 3.1% of women in India are screened. I just wanted to put in a slide wherein you can see the EVA, which is mounted on a tripod stand and ready to use. Now, this is a picture of our clinic in Apollo Hospital where we are doing screening. This is a picture to show you the workshops that have been conducted on the premises in Apollo to actually familiarize the new EVA users with the device. This is the workshop in session. Now, a few things about the features of mobile colposcopy. The enhanced visual assessment EVA system has been FDA cleared in 2016 and CE approved in 2015. It is built around a smartphone with auxiliary hardware, case, lens, flashlight. There is a dedicated app for acquisition of the image and the clinical workflow management, which makes it really easy to use, and the online storage of images in a secure web portal. It is designated as a smart medical device with special features. So we had 6 sites for this pilot study, partner Hospital Apollo, along with mobile ODT. And the sites were 3 of them in Chennai in southern India and 3 in nearby southern Indian states. And the sites treated different patient populations, the key variation being age and socioeconomic levels. So these are the site characteristics, the number of patients per site, and the socioeconomic status of these patients. So when we see the data of patient population as regards to age, we see that the maximum number of patients were from the age group of 30 to about 45. And when we look at the socioeconomic level, we find that the maximum number of patients came from the middle socioeconomic level. So what was the methodology? The methodology was patient information was documented on the mobile colposcope, and then we had the conventional pap smear was taken, because the pap smear is a must according to the local Indian guidelines. And patient was imaged by the mobile colposcopy. The images were stored in the software, and the decision support job aid was used to document the exam. And we'll go into that in a little while. And the biopsy was collected if necessary. So decision support job aid, we see that when we look at the first section, we see here that the details have been taken, the images have been stored, and now we've come to the decision. So what are you going to say will be the decision? Are you going to say it's normal? Is it abnormal? Or is it an incomplete exam? So you go to the next option. The next option says diagnosis detail. Suppose you have selected abnormal. Is it precancerous, suspected cancer, cervicitis, or other? And then you go to the next step. And are you going to treat it on site? Are you planning to refer the patient? Or are you going to not treat the patient at all? You think it's not necessary. Then you go to the next section, next option in treatment detail. Are you going to use antibiotics? Are you going to do LEEP? Are you going to do a surgical excision or other? So having actually gone through all of this, we go now to the decision summary, where we say we have diagnosed it as abnormal, and then we have said that the diagnosis we think is cervicitis, and so we are going to treat it right there and then, and we're going to give them antibiotics, and we're going to ask her to come back and rescreen in 1 year. So this is the decision tree for the job aid. So sometimes it's easier for us to understand if we have a tree. So you take that this is the decision. So is it normal, abnormal, or exam incomplete? Suppose you're saying it's abnormal, then do you think it's precancerous, suspected cancer, cervicitis, or other? And then the flow chart goes on from there. Data analysis. Now, when we have put together all our data, we find that we have 3 sections of data. Firstly, data which is aggregated at the back end, all of the data that we have collected and put on the device. Secondly, data which is routinely monitored and audited for quality. And thirdly, data reports which are created by the site and the provider. So when we look at the data which is aggregated on the back end, what is that? Firstly, it is the images that you have captured. Firstly, it is the patient metadata, then the images that you have captured, then the clinical decisions in your job aid, and the cytology which you have done, the pap smear reports, and then the Q&A results. So having done all of that, you have all of this data which is aggregated on the back end. So what was our impression when we have actually collected all of this data? We saw that when we weighed visualization versus cytology, what did we actually find? We found that there are high rates of cervicitis rather than dysplasia. And we find that there is a higher variation in cervicitis rates across all of the 6 sites. And it is positive for dysplasia. There was a positivity for dysplasia in the higher age groups. And there was a positivity for dysplasia higher in visualization than in cytology. And this is a very important point. Socioeconomic level versus disease. So when we looked at that, we found that dysplasia was common in poorer women. Cervicitis was common to everyone, and in general agreement. And these are findings which is in general agreement with centers worldwide. When we look at age versus disease, we found that rates of cervicitis generally increased with age. And dysplasia was also, we found a greater percentage of women in the postmenopausal group with dysplasia. So having looked at all of our data and having looked at the device itself, what is the discussion that we're going to have? We're going to say that the EVA hardware and software actually mitigated many operational challenges that we would have had with just a visualization with the naked eye, visualization with acetic acid. Also, integration of data on the back end made by generating this data on the phone itself made data reporting much easier because we had all the data right there in the device. Now, without software infrastructure, data collection and analysis would have been impossible, and especially if we were screening in the remote areas. Easy to detect variation across sites and providers, and better planned resource allocation could be done because of our data collection. Quality assurance by site leaders ensured high quality images across the sites. But we had one limitation, and that was that data could not be compared against histopathology because of the reluctance of many of the patients to actually undergo the biopsy. I just want to say a word about integrated telecolposcopy. In this, what we do is we use a video chat app along with screen sharing to connect to providers, to connect providers to remote experts. So here you have a patient and you have a provider here. The patient is actually being examined by the provider, and through the telehealth solution, EVA system telehealth solution, they are actually being counseled by the medical expert. So it virtually brings remote experts to the screening camp. And this is an example where this setup has been useful. And we see that this has been implemented in Southern California, where you have the partner of FPA Women's Health, 3 clinicians proctored for 100 sessions with 1 remote expert. So this is FPA Women's Health. These are the locations where they have screened patients, and you can see that this is the screening of a cervix is being done, and the provider is chatting with the expert. So concluding thoughts, what would be that the mobile colposcope with its digital features has actually revolutionized the field of colposcopy. And where colposcopy was available only to the affordable, it is now possible to take the device to remote locations and screen for this dreaded disease. And the fact that we can upload the images and the decision platform on the cloud makes remote evaluation possible. And I do hope that the government would begin to use EVA for the underserved population so that more and more women are screened early on. And we need to understand that screening is actually early detection is actually the cure. So let us go forward in this new year to actually screen our patients and help them to a better future. Thank you so much for your patient listening. Finally, I would like to make the acknowledgements for all those who have taken part in making this project a great success. I would like to acknowledge, first of all, David Levitz, who is a super person in analytics, who has done a lot of work in data analysis for this project. Then I would like to acknowledge the Apollo Research Initiative and the Mobile ODT for giving me an opportunity to be the lead investigator for this pilot study, for all of their support that made my job exciting but easy. I would appreciate PAJOG for accepting our work for publication, and a great appreciation for SciTech conferences for giving us the opportunity to present this work. And finally, I would like to thank God for helping us to do this project in spite of 6 centers working together in tandem and making this a great success. Thank you.